All right, let's dive right in. Today, we're tackling a super important drug class for your NCLEX, first-generation antipsychotics. Getting these right isn't just about scoring points on the exam. It's about proving you can keep your patients safe. So let's get you ready.
So here's our game plan for today. First, we'll talk about why these drugs are such a big deal for the NCLEX. Then, we're going to hit the major emergencies, NMS and EPS, head-on. After that, we'll break down the low and high-potency drugs, build a safety plan you can actually use, and wrap it all up with a quick review to make sure it sticks.
So you might be wondering, why does the NCLEX care so much about these older drugs? Well, it's simple. They are the perfect test of your clinical judgment. Can you spot a life-threatening problem? Do you know what to do about it, like right now? That's what they're testing.
Okay, if you only remember one single thing from our time together, please make it this. This is the absolute core concept. These drugs work by blocking dopamine, which is great for taming things like hallucinations. But, and this is a huge but, that exact same action is what causes all those serious movement side effects. It's a constant, delicate balancing act. All right, let's not beat around the bush. We are going to tackle the two scariest, most tested complications right now, at the very beginning. Because if you can master neuroleptic malignant syndrome and extrapyramidal symptoms, you'll feel way more confident with any question they throw at you about these meds.
Let me be absolutely crystal clear here. Neuroleptic malignant syndrome, or NMS, is a full-blown medical emergency. Yeah, it's rare, but it can be fatal if you don't catch it and act fast. Your number one job as the nurse is to spot these signs before things get critical.
So how do you spot it? Well, you're in luck, because there's an awesome memory tool, PHARM. Think F for a super high fever, A for autonomic instability, that means blood pressure and heart rate are all over the place, R for severe lead pipe rigidity, and M for mental status changes like sudden confusion. You see these together, you better be thinking NMS.
Okay, so you see the signs. What do? The number one, top priority first action is to stop the antipsychotic. Hold that dose and get the provider on the phone stat. Then, of course, you'll start supportive care, cooling blankets for that fever and giving meds like dantrolene to help those rigid muscles relax.
All right, let's put this into practice. Imagine you walk into a room. Your patient is on haloperidol. Their temp is a scorching 104 degrees, and their muscles feel like a rock. What do you do first? The only right answer is to recognize this as a potential NMS crisis and stop that medication immediately. That's always step one.
Now, let's talk about the other big one, extrapyramidal symptoms, or EPS. There are 4 main types you have got to know. First is acute dystonia. Think sudden, painful muscle spasms. Maybe their neck twists or their tongue pushes out. Super scary. Then there's akathisia, which is this awful inner restlessness that just can't stop moving. Parkinsonism looks just like it sounds. Tremors, rigidity, a shuffling walk. And finally, the big one, tardive dyskinesia. These are those involuntary movements like lip smacking or tongue rolling. And here's the kicker, this one is often irreversible. That's why spotting it early is so important.
Okay, now that we've covered the big, scary emergencies, let's get into the specific drugs. We're going to start with the low-potency ones. The 2 key words I want you to burn into your brain for this group are sedation and hypotension.
Okay, this slide right here, this is NCLEX Gold. You should probably take a screenshot. It perfectly lays out the fundamental trade-off. Low-potency drugs like chlorpromazine, they're going to make your patient super sleepy and dizzy when they stand up, but they have a lower risk of those awful EPS movement disorders. High-potency drugs like haloperidol, they're the complete opposite. Way less sedation, but a much higher risk for EPS and NMS. You're basically trading one set of problems for another.
So let's zoom in on the classic low-potency drug chlorpromazine. For the NCLEX, you should expect questions about sedation and orthostatic hypotension. But the really unique risk you gotta know is photosensitivity. Teaching your patient to use sunscreen and wear hats is a super common NCLEX topic. Oh, and don't forget that weird random fact that it can be used for intractable hiccups.
Time for another quick clinical judgment check. Your patient on chlorpromazine stands up and immediately says, "Whoa, I'm so dizzy. What are you thinking?" This is textbook orthostatic hypotension, a huge fall risk with these low-potency meds. Your priority is keeping that patient safe.
All right, let's switch gears and talk about the high-potency drugs. From now on, when you see one of these drugs on your exam, I want a giant alarm bell to start ringing in your head screaming, movement disorder risk.
This is where we see the absolute worst of EPS and NMS.
And here is the star of the show, haloperidol, or Haldol. You will 100% see this drug. It's the go-to med for managing acute agitation and delirium in the hospital setting. But that high potency comes at a cost, the highest risk for NMS and severe EPS. And one more thing, the IV form can cause QT prolongation, which means you've got to be thinking about heart monitoring. Now this is a classic NCLEX pearl, so listen up. Fluphenazine has a long-acting injectable version that's given just once every few weeks. This is amazing for patients who have trouble remembering to take their pills every day. But what's the catch? Well, because it's in their system for so long, there's a really high sustained risk for developing those long-term movement problems like tardive dyskinesia. So remember how these drugs block dopamine? Well, think of dopamine as the brain's off switch for a hormone called prolactin. When you block dopamine, you take your foot off the brake, and prolactin levels can just shoot through the roof. This can lead to some really distinct and pretty distressing side effects, things like breast development in men, milk discharge in both men and women losing their menstrual periods, all key signs you need to be watching for.
Okay, wow. We have covered a ton of risks and side effects. So let's pull all of that information together into a clear, actionable nursing plan. Think of this as your safety blueprint for taking care of any patient on one of these typical antipsychotics.
Here are your non-negotiables. These are the things you absolutely have to do. You have to assess for any abnormal movements before they start the drug and keep assessing. You have to monitor their vitals, especially their temperature, every single day for signs of NMS. You have to put fall precautions in place. And your teaching needs to be sharp and clear. If you get a fever or your muscles feel stiff, you need to tell us immediately.
All right, deep breath. It's time for the final stretch. Let's do a fast-paced review to put your knowledge to the test and make absolutely sure you're ready to crush it on exam day.
Okay, check out this classic NCLEX style scenario. You have a patient who's been getting those long-acting fluphenazine shots for 2 years. Today you notice they're doing this constant involuntary lip smacking and tongue rolling thing. What cues are jumping out at you here?
So what are we thinking? And more importantly, what's our priority action? Those facial movements, after long-term use, that screams tardive dyskinesia. Now, your priority isn't just to stop the drug. The first thing you need to do is a formal assessment, maybe using a tool like the AIMS scale, document everything, and then notify the provider right away. Catching this early is everything.
Let's wrap up by talking about the most common traps students fall into. Do not confuse the mental status changes of NMS with a worsening of their psychosis. Don't ignore those first tiny little facial twitches of tardive dyskinesia. Always take orthostatic hypotension seriously as a fall risk. And please, never underestimate how truly terrifying an acute dystonic reaction is for your patient. So I'll leave you with this final thought to take with you. After everything we've covered today, all the emergencies, the side effects, the risks, what is the one single safety check that is now burned into your brain that you will never forget every single time you give one of these drugs? Really think about that, because that is the heart of clinical judgment.